But listen, you only do this if you want to have more happy patients and clients that refer to you and love you guys and stay longer and are fine with paying more out of pocket instead of.
Dave, what are you doing for RCM or just in general within your business?
My out-of-network biller, his whole team handles it. So that's why they charge 10%, which is probably the highest of any biller in the country. They do everything, I'm sure, mostly manual. They have their own in-house medical record that you only use if you're a client with them that they built. It doesn't look great. So then, we also have JNAP as our therapist-facing medical record. But anyway, in terms of what they do, they post payments, they show what's pending, they show in their medical record, like what's been paid and what's the notes on, following up on. I mentioned this to Paul Singh and Adam at Strata a while ago when I had a Zoom call with them. And they were like, yeah, we can't do that. Like, our system doesn't do that.
Can't do what?
So Strata, I presented, here's what my biller does. Can you guys do this? And they're like, oh no, that's like way boutique. Like, that's like way high touch. Because my biller tries to find the allowable amount of every out-of-network insurance plan. So some of the allowable amounts might be $134. Some are, $247. Like, every plan is different. So we want to find what's the allowable amount to legally or ethically, maximize the coding and the billing and all that type of stuff. So what do we do? I don't know. I mean, he handles it. The whole team handles it, the billing team. So that's who I use.
Yeah. I think this is a great example of, different scenarios require different touch points. Before we came on today, I grabbed a couple notes because I was going to talk about the idea behind self-checkout versus a human cashier. When would you want one or the other? I ran a poll on LinkedIn real quick because if I've got a couple items in my basket, I just want to go self-checkout. But if I'm looking to figure out what wine do I buy for this dinner that I'm preparing tonight, I need a human to help me with that.
Yep.
At Dave's level, at my level, I'm like you. It's easier to just have a human look across a handful of claims that are causing me problems, identify, okay, this Aetna Medicare Advantage has a 5% coinsurance on the 20% that Medicare doesn't pay versus this Aetna plan has a 20% coinsurance. They're two Aetna plans in the same geographic area, but they're different plans, and so at scale, technology is amazing. What I find interesting about what Jimmy is going through, my understanding was there were maybe federal laws or something passed that payers couldn't use AI to identify and automatically deny or reject claims. I thought that was a law that had passed, but I know providers are using AI to optimize claims to improve payment rates. I have no idea. And for the record, I had never heard of RCM before 2 years ago, maybe.
Really?
2 years. I was like, what the heck is RCM? I start getting all of these messages inbound from RCM companies. And I was like, what? And then of course you figure out, okay, revenue cycle management. But even within that, in my world, at my scale, it's just not a thing. I would do it internally, manually. So
yeah, if you're going to learn about it in business school away from healthcare, it's, when you do something on Monday, how long does it take to get paid for that thing? There are some industries where you get paid on the spot. Actually, maybe you get paid before the service or the product is delivered. And ours is convoluted beyond measure. And a lot of people, I think Jamie Schreier has a great line, which is like checkbook accounting. Jamie's like, I had this thriving practice. And if you asked me if I could make a purchase or a hire and what I would be like 6 months from now, he was like, is there money in the checking account now? Then yes, I'll make that purchase. And it should frighten people because you don't know. One thing that you can do with automation and AI is you can look at individual payers. Now you could do this with a team manually. It just takes a while. If you can somehow automate this almost like a spreadsheet or like a spreadsheet that thinks, you can see which are the accounts, which are the third-party payers that are either not paying up to par or paying too slowly, right? Not getting paid at all or not getting paid enough. Those are two pain points. Getting paid slowly is not fair either. We have an agreement. You're going to pay me on time because I got people waiting for me. I got therapists. I got a landlord. I've got other people that I owe money to or I want to expand. That's not fair either. So that's another component to knowing cash flow or where things are coming from is important.
Now,
So Tony, you don't have any of this, like when you're chasing down claims, things that get denied, they ask for more billing, more coding, whatever. Like you guys haven't had any of those issues over the past 5 or 10 years. Like you don't have any issues with collecting, like something's denied and for sure, like the coding is proper. It was submitted in a timely fashion. The notes are there, like referral, prescription on file. If it's required, a signature, POC for Medicare, whatever. Let's say you have everything covered on your side. You have not had any denials, not any issues of any of these claims over the past couple of years?
I'll tell you, it's less than 1% of everything, like significantly less than 1%. I'll tell you that in my area, we have a handful of payers and we have all the majors, right? So United, Humana, Aetna, MedMutual, Blue Cross, plus Medicare, Medicaid, and managed care plans. And we have workers' comp. Okay, we've got a shit ton of different payers, but we have streamlined it effectively enough. We've put in the work on our end that no, we really don't get situations where there's like a denial, a non-payment, a rejection. I want to say it's because we created systems that prevent those mistakes from happening before they happen. They used to happen. They just don't happen anymore. And so we have manually automated systems that prevent that from happening. Now, I'm not going to say it produces the best result. I'm not going to say it produces the highest income available, but it's like I will sacrifice maybe higher reimbursement to minimize inefficiencies. And it's been working for us. And to, I think, Jimmy's point, a lot of claims that might go unsubmitted or not resubmitted or not followed up on, 20 years ago, like literally 20 years ago, when we brought our billing in-house, we used to outsource. We used to pay 7%. We brought it in-house. It was when we crossed $1 million in revenue. I was like, if I'm paying $70,000 for somebody else to duplicate all the work that my internal team is doing anyway, that's $70,000 less I have to put into following up on claims that get denied or rejected. So it was cheaper for me to let those claims go up to that $70,000 threshold and bring my billing in-house. Plus, it gave me more control so I could make decisions on cash flow that an outsourced billing company wouldn't be making. There were years that I wanted to defer income to the next calendar year. There were years that I wanted to accelerate income. Like there were a lot of decisions, and these were, $130,000 in income that I want to push out of December into January. I can't do that with a billing company because they're relying on that money. But if it was internal, I can make those decisions. So that was the impetus for us. But this was before technology. This was all manual. This was us sitting down and looking at each of these cases. Now, I will say real quick, we had a spreadsheet, a Google spread, or no, not Google. This was Excel. Every tab was a payer. So I'd have the Aetna tab, the Humana tab. Then when you would go to that tab, you would see how long is this payer taking to pay us? How much is this payer paying for what CPT codes? What were the previous mistakes that had happened with this payer that caused the denial or a rejection so that we don't make those mistakes again? Mm-hmm. And the workflow was, okay, we've got a Humana referral coming in. We go to the spreadsheet, we open the tab, we follow the instructions, learning from the mistakes that had happened previously. So the mistakes never happened again. I don't think therapists in this, one location to 5 locations really care to do that. They just want to treat patients. They don't want to spend time geeking out on spreadsheets and figuring out these systems.
Respectfully, like even with, Jimmy in this company in this new role, like I wish that these companies didn't even have to exist. I wish it was just
Sure.
I wish it was easier for therapists to be paid. And I mentioned on the last episode, and Tony wasn't with us, it was just Jimmy and I was saying, like, it's so much easier to have a credit card on file for a patient. They have already signed, they already agree the dollar amount. The visit happens, their card gets charged, we send them an email receipt, their money from their bank account hits our bank account in like 2 or 3 days. That transaction is settled. It's final. And as long as you're not doing anything wrong by the patient, They're not going to do a credit card chargeback like the way that these insurance companies do all these recruitment and whatever. And I know Tony's going to say, well, it's because sometimes these billing practices or your whatever, bad coding, whatever, Medicare calls back money. So, yeah, okay. But the transaction between myself and a self-pay patient is settled regardless of how many minutes we were there, regardless of how good our clinical note documentation was, as long as the note is the, sufficient minimal standard for the state practice act or whatever. It's crazy that there's 26 points for revenue cycle management for this claim, like, the bill on Capitol Hill floating around, ping pong in between all these parties and this, 26 point revenue cycle management. Anyway,
that's why it's so expensive. That's why healthcare costs so much. That's why it's so inefficient. And walking into the garage before I got on with you guys, the thought that came into my mind that I knew I was going to bring up was, look, I'm a biller that does physical therapy. I'm not a physical therapist that also does billing. I'm in the business of helping patients turn their insurance benefits into revenue, into reimbursement, into whatever, cash. That's the business that I'm in. You're not in that business. You optimize for the business that you want to be in, which is direct to consumer, delivering an amazing experience. I'm not in that business, but we both call ourselves physical therapy, which does bring me to another point that I want to get your guys' opinion on. Jimmy,
Here we go. Perfect segue. Here we go.
I shared this on a post. Have we outgrown the profession? Are we living in a bubble? The three of us here, there's 21 viewers right now listening to the stream. Like, there's 240,000 or however many licensed physical therapists out there. We're so stuck in this bubble that, we can't even think of the other 50% at the bottom of the profession who don't give a damn about what's happening, what's going on. They don't want to hear anything about being better. They don't want to do Con Ed. They don't want to learn. They don't want to improve. They just want to survive the day and then get the heck out of the skilled nursing, the acute care, whatever setting they're in. So my question to you guys is, just like Dave illustrated, did we outgrow the profession? Are we still going to try and waste our time lifting, quote, physical therapy out of where it used to be? Or can we just move past it? Can we come up with something that's more comprehensive or reflective of what we actually do? Jimmy, what do you think?
Well, I feel like we've had two different conversations or two different big topics that maybe this is joining, like Voltron. One, which is, are we more limited? Are we more handcuffed by a license than without? Like, if someone went through PT school and got all the knowledge and then said, I'm not treating under my license, I'm treating as a coach, as a trainer, because now that there are no or less restrictions on what that person can do and how they approach helping that person achieve their goal. So that's one thought that comes to mind in terms of have we outgrown the profession? The other conversation we had, and it's like a time capsule, we said, hey, we've got less and less students applying for PT school. We've got, people leaving the profession en masse. They're going in crazy in droves and leaving. At some point, do we merge together two or three different skill sets and it becomes a new profession? I mean, PT was not a thing, and then it was a thing. Like
restoration therapists.
That would never happen. I'm like, well, PT wasn't always, like, it wasn't a thing, and then it was a thing, right? And then occupational therapy became a thing, and it's similar but different. So at some point, do you take a PT, an OT, a physiatrist, an NP, a PA or something, and do you take what works really well out of those and make a Voltron out of that? So have we outgrown the profession? I sure hope so. I hope we're progressing, right? If we're still doing the same thing, did your professor say that to you? If you're practicing the same way in your 20th year that you did in your first, you're probably committing malpractice because things progress. And if you're not changing, you're part of that bottom percent. There's Voltron.
Yeah, why do you keep saying Voltron? This is what I'm thinking of. What does Voltron mean to you?
So I was saying, if you took the best parts of a PM&R doc, a PA, an NP, a PT, an OT, lump them together, they are greater than the sum of their parts.
We both needed the explanation now. Okay.
For people listening, what I don't even remember what we built.
In my brain, it was very easy. So you imagine Voltron.
No, but I mean, what was the cartoon? They were cats?
Voltron?
He's made of different parts. That's Jim's point,
so
right?
Voltron was 5 lions. So left leg, left arm, right arm, and the torso and the head. There are these lions, and they fought evil. But when they faced like an enemy that was like huge, they had to come together and create a robot to then fight that thing. And they were always like robot sized.
Got it.
All right. I got the contrarian stance on this, like usual. We have not outgrown the profession. We have outgrown the third-party payer system.
Okay.
But what does that mean?
Now,
what is it? Right. We meaning anyone that wants to pay therapists, keeping up for inflation, retain therapists, pay them a livable wage in most major metros. I mean, dude, it's crazy that, like, you see these posts in Tony's group and Learn Medicare Billing, all these other groups, like, looking for a Medicare therapist here, looking for a Medicare therapist there. And it's like, in 10 years, you're still going to be paying a therapist the same $65 an hour or 50 or 60 or Luna PT. How long in 10, 15, 20 years can they continue to pay therapists $70 a visit or $80 a visit, and Medicare is going to pay $108 to $120 per visit? We have outgrown the third-party payer system.
I don't think we have. I think we should have, but the system persists. So until we change culture,
it's getting compressed, and it will only continue to get squeezed.
So the question is, okay, if we have 240,000-ish licensed PTs, not counting other clinicians, and I mean, realistically, how many, on a percentage basis, how many of those are actually moving out of the third-party payer system? Actively moving out of the third-party payer system?
I have no idea. I don't know.
Less than 1%. I gotta think. So this is where
I would say 25%.
No, we're actively moving out away from their acute care, SNF, home health.
I mean, but then there's all these, the uncaged clinician or your group, Learn Medicare Billing.
That's my point. We're in such a bubble. We can't even imagine. We can't fathom how much is still out there. I would argue less than 1% is actively moving away from third party. So at that point, you go back to, it's like, are we going to waste our time, money, resources, passion, trying to drag everybody out of what they're used to, or just forget it, cut the ties, cut the umbilical cord, and just go our own way? I think we go our own way. We've got some comments here. Prince is asking, how do you typically manage and track patient copays in your practice? So Dave doesn't have this issue because he just gets paid, right?
There's no copay. It's just pay.
Well, if we're taking the out-of-network insurance benefits that we're using that biller for, we pay the biller 10%, we are tracking copays. So we track it. How do we track it? The patient was seen today. They already hit their out-of-network deductible. Then their copay is, $30 a visit moving forward. How do we track it? Like, the visit was complete. My other team member looks at the medical record. This person was treated today at 8 a.m. They have a $30 copay based off of a little digital sticky note inside their account. So we know how much they're to be charged, and then their credit card is run for $30, and they get a $30 receipt.
Now, for the record, Princey's with Spry. I'm going to talk to those guys, kind of get a better idea of what they're doing. It's more of a... It's more of an AI forward EMR. They're a little bit of the newer kids on the block. Katie Wadlin was here. She said, goodness, I had a disaster experience with Athelas. My hunch, we're just trying to put a square in a round circle. It's just a mismatch. David was here this morning. I don't know if he's still around. I hope he is. I love watching what this guy is doing. He's got some amazing stuff going on with,
and he's left the third-party payer system.
Yeah. He's moved, moving or moved out of it. Scott, Jimmy, he got the Voltron analogy. I swear there was they were electrocats or something. Weren't they called something? The cat robots?
Are you confusing Thundercats and Voltron?
Yes, that's what.
Don't do that. Totally different universes.
All right, Dave is right. The system is broken.
Agreed,
Scott.
Agreed. The system shouldn't exist like that.
Dr. Bo jumping in live from Colorado, and he quoted he posted my quote in the comment. The system is getting compressed and will continue to get squeezed. Yeah. So
Which truthfully, I mean, I think it's a good thing because I think therapists have been too comfortable for too long in the status quo. We need to change things. If everybody's complaining, but nobody's making a change or the majority isn't making a change, the payer is going to make us make a change. You know, as long as we're too comfortable to get off of that payer system, we're never going to get off the payer system, but we're always going to be complaining and suffering and crying about not enough reimbursement. Jackie's here, you guys. Jackie was on with Dave and I. That was a great episode. She was talking about going our own way. A whole bunch of people out here, but
and Jackie's doing it as well. And when we talked to her, Tony, I was really impressed that she just was so confident by saying like how they even dropped Medicare in her area of 4,700 residents.
Par with Medicare.
Okay, so what does that mean? What's the
So non-par versus par with Medicare, you're still contracted. You still have all of the obligations of Medicare. You still have all the requirements to submit claims. You're limited to what the non-par allowed amount is, but you are allowed to collect up to 115% of the non-par allowed amount. So basically...
So confusing already.
I know. You are allowed to collect a little more, which does increase total collections, but you still have a lot of the restrictions of Medicare itself. But, you know, it's working for them. They're doing great with it. I know in their future, they're going full like self-pay all the way because they have built such an incredible organization.
The system is designed to get the result it gets.
Right.
It's supposed to be confusing.
Dave, let's talk about your new offer. What's a memory pod program?
Oh, yeah.
Yeah, sure. Okay, so we have an existing client, and they are, let's see, I think they've been with us for a few weeks, so they've already spent, I got an email from the assistant, but this is someone, let's just say it's someone who's like 70, 80 years old. They're a very successful business person, and they can afford $350 out of pocket per visit. The assistant emails me on an email with like some other assistant and like the client's son and asking if we do cognitive therapy. So I asked a few questions just to make sure what are they looking for or whatever. And then what the response that the assistant said was basically like, I was like, oh, so you're looking for like, you know, potential cognitive engagement, you know, hand coordination that we already mentioned, upper extremity stuff that she wanted us to focus on. And the client wants us to focus on like almost like some OT stuff, like fine motor stuff, like zippers and buttons and that type of stuff for this client who's like around 70 or 80 years old. So I get this email Monday from this assistant and a whole bunch of people attached to the email that's asking, hey, do you guys do cognitive therapy? I reach out to my therapist. I say, my therapist who's treating this client, and I say, hey, the assistant is asking if we do cognitive therapy. If I got us, or if we started using Blaze Pods or something like the Blaze Pods for reaction and decision-making and hand coordination, hand-eye coordination, and maybe it helps cognitive benefit, you know, there's cognitive benefits and memory benefits or whatever. I said, are you comfortable with this? I sent him a video, like, here's Blaze Pods, like, he's like, yeah, I've seen that before. I can use that. I can do that, whatever. Okay. So we'll pause the story for a second. Tony, if you had a patient or across, you know, the country, when a patient reaches out like this, what do most therapists do? So they don't have the Blaze Pods. They're thinking maybe I should get the Blaze Pods. What do most therapists do?
I don't know. I really don't know. Well, Jimmy, what do you say?
Send them a link. They'd be like, hey, get this. Here's the link.
Exactly. They would say, here, we don't have it right now. So either we could buy it, we buy it on our own dime.
Okay.
Or we send them the link and say, hey, you guys buy it and have the Blaze Pods there so that then my therapist shows up and then we can do this cognitive therapy that you're talking about, right? And then I thought, well, the Blaze Pods, I don't know why, and maybe I need to check them out or test them out, but they're like $300 or $400 for the four. Yeah. Like they're kind of expensive.
They're really expensive.
Really expensive. And I don't know how heavy they are. I should have looked into that. So I was thinking like, well, if my therapists are going to start complaining about, you know, that they're heavy to travel around New York City with, you know, maybe it makes sense for the clients to be buying them themselves. No one wants to buy the Blaze Pods as a client themselves. So what do? We put a name to it like we've talked about before. And instead of using Blaze Pods, I said, memory pods. I call them memory pods in the email, and I say, oh, you guys are looking for cognitive therapy. So yeah, we do. We have a memory pod program for new clients. It's $2,150. You guys are already existing clients, so it's $650. So basically, we could get the Blaze pods covered, so this client can start using them. Cog pod, there you go. Cog pod, cognitive pod. I like that, Tony. Tony just posted that live on a comment. So I said to the client, this memory pod program is $650 for existing clients. I price anchored by saying $1,250 for new clients. So now I got to go put that on our website as the new offering or program on the front end. And then the assistant was like, all right, I'll talk with the client's son and we'll go from there, and we'll see, whatever. But yeah, sounds good. And so they haven't pulled the trigger yet, but it's just an example. Like the old me and most therapists out there would go spend the $300-$400 out of their own pocket for these Blaze pods, and then not package it in a way that makes it a little more serious, a little bit more appealing, a reason as to why they should pay for the Blaze pods. Obviously, we can pay for them, but if there's a way where I can have them pay, why wouldn't I?
Yeah, I will say, so they are super tough, like durable. People are stepping on them, jumping on them, punching them, doing all these things. They are really lightweight and compact. They're super easy for mobile. That being said, when I see the pricing, I'm surprised, but like most product companies, there's always discounts and things like that. Here's what threw me off. You said pod, and for some reason in my head, I was thinking there used to be something like a metabolism tester. You would literally get into this. Yeah, the bod pod. You get into this thing that looked like an egg. And I was Google searching, like, what is he talking about? So first you said cognitive, which immediately shuts my brain off because I'm like, I'm not going to do anything with cognitive. Then you said pod, which then again shut my brain off a second time because I was thinking this huge egg. Okay, everything makes total sense. Now, my program, what I'm trying to do with them is I do want the consumers to buy it. I do want them to use them at home. I want to create the online version. For me, it would be total knee replacement specific or gait training. But the whole idea would be, we get the consumer to buy it. It's home exercise equipment. They use my affiliate link, which I shared here, which gives me a commission on the purchase. And then I generate video content on a daily basis to give them new stuff to do every time. It's not direct one-on-one care. It's not billable physical therapy. It is, here's how I use the Blaze Pod in my business and my practice. You guys can use it like this too at home. All right.
Well, so now that you understood it was like Blaze Pods, does it make a little bit more sense now?
100%. Yeah. And just like,
are they that heavy? I mean, now I've seen them, right? But like, so I guess my question would be, so wait, how are you rolling this out? So you're saying, hey, for this program, you pay X, you get a set of pods, and you're going to get X number of visits. It wouldn't be better to buy a set of pods for each therapist and sell that so that or do you like the leave behind? Like, listen, if I'm here twice a week, I still like you having the tool to follow up with what my therapists say.
So when I emailed the offer, I didn't say that we're leaving them behind. They are paying for us to buy the first set of Blaze pods. Then my therapist takes them and he can also then use them with other patients. Oh,
okay. Is there also an option for them to buy Blaze pods through you to do this thing that they now love doing and feels good for themselves or their loved one after, and then this way they get affiliate link?
I just made it simple and said, like, here's the program. It's this much for new clients. You guys are existing clients, so it's this much. So I didn't want to do like multiple options and offers because then sometimes people get confused. So it's like, here's the thing. Oh, and then in the email, I should have mentioned this. In the email, I grabbed 2 links from Instagram, 2 video links. I went on Instagram, I went hashtag Blaze Pods, or I looked at their profile or whatever, and I pulled 2 video clips of patients using Blaze Pods with a physical therapist. And the patient in the video was like a 70 or 80-year-old male, just like my client. So I linked those 2 Instagram videos in the email. I said, here's an example of an older gentleman sitting down doing these memory pods, and then an older gentleman standing doing the memory pods where they're up against the wall. And then I said, Mr. So-and-so, could do this in a seated position in a chair or standing, because the person has mobility deficits. I haven't met the patient directly. So that way there's no balking on like, oh, well, he can't stand for that long and do it. So I'm like, here's an example of a video of someone doing it sitting down, a video of them standing up and doing it. They click on one of those or both of those links and they'll be able to see like, okay, here's the actual item, the actual pod thing that happens to be the Blaze pod, but I just renamed it. That's all.
So this is where the snowball starts rolling down the hill, right? So Dave got this inbound message that sparked an idea that started to get developed. Now you take that and really the first thing that I would think is, okay, so there, and I know exactly the videos that you're talking about, but then you're like, hey, let's create more videos like this. So you talk to somebody who's, maybe already got them or wants to get them, or you guys create them. You start putting that content out there. Then you say, well, shoot, if I've got all these videos out there, I could start doing, now maybe not you, but somebody else, RTM. Because through RTM, whether I'm using Sarah Health or any of the other RTM platforms, I can include the link to the video. So, I've got the revenue coming in from the RTM. I've got the revenue coming in from the memory pod program that I'm doing. I've got the revenue coming in from affiliate income if the client is buying their own devices. I've got YouTube revenue coming in. And then if one of these kind of hits and all of a sudden now you got 1,000 views, now that piece of content has proven itself to be valuable to viewers. Now you grab this stuff, you put it into a digital course, and now you've got this digital product that people could use. It's like this is the framework that works. And it all starts with this little inbound message that came to you. And I was like, hey, Dave, do you do this? Well, no, but maybe it's worth exploring.
I think the example of two of you not understanding Voltron is a really, really good paradigm, because Dave saw something and Tony read it and saw or thought of something completely different. It was like, I don't even understand what you're saying, or I understand that and they see this and I'll raise you this. I think the answer probably for Dave is do exactly what he's doing right now this way. And when that's rolling so well, then iterate on it, or then go ahead and yes and that.
Now let's take this into marketing. So Dave, what are you doing in regards to physician marketing? Letters, referral pads, and I know people think referral pads don't work, but I guarantee they do. What are you doing now?
Yeah. So I spoke with, a week or so ago, I spoke with a colleague that previously had an out-of-network practice that he scaled to multiple locations and $4 million in revenue. So I was saying to this colleague, I said, I spent a lot of money on Google Ads in February. I said, these physician referrals, like they're not predictable. Google ads and, paid ads are more predictable because you crank it up and you get more leads and you typically get more conversions and all that. And he pushed back and he's like, wow, I built a $4 million business on physician referrals. So he's like, what do you mean they're not predictable? I'm like, they're not predictable. He's like, tell me what you're doing. And then he's like, oh yeah, you're not like really marketing to physicians. So like here's what you should do, or here's what I would do. Here's what I used to do. He goes, what's your plan around physician marketing? And I'm like, oh, I don't have a plan. Like I don't have an actual like game plan, meaning like, okay, you get a current patient, like we have current patients. And he goes, all right, so your current patients, do you have a spreadsheet of all of your current patients or past patients, all their primary care physicians, all their neurologists, all their physicians? And I'm like, no. He's like, well, that's where you start. He's like, you make a spreadsheet or, take it from your medical record, whatever, all your physicians from all your current or previous patients, and you send them a letter on, concierge. Here's my my paper card, a little thank you note. Inside is like the little signature, and then I can write in it. And he goes, write those physicians and say, hey, Dr. So-and-so, we're treating our, your patient, our patient, shared patient, Tom Jones, whatever. We're working on XYZ issues. Look forward to keeping in touch or collaborating in the future, or, let me know if you have any questions, or we'll reach out if there's any red flags or any, things that don't add up and they need to be referred back or whatever. So sending a paper letter to a physician that has no idea you exist to get out of obscurity. So that's one way to start. And then obviously, calling in, the whole normal thing, calling in, trying to, speak with them, drop off pens. I don't have them handy, but we have pens. And then we have the referral pads, right? So I just dropped one of these off on Monday of this week. This is, now these are not like Tony Maritato's. This is not where we list every practice in the area, which is a great strategy. We talked about it before. This one is specifically for us. I emailed other concierge practices. One, for example, they got back to me on Monday or Tuesday and they said, we don't use these. I sent them an email and I said, hey, some physicians love these. Some physicians hate these, or, some physicians use these. Some physicians don't use these. I'm not sure where you guys are at, but would Dr. So-and-so, and I'm messaging like the person who's my conduit into the office, the one of like the main people. Yeah, one of the office managers. So I said, hey, does Dr. So-and-so use these or not? Like, I know some physicians like these, some physicians don't by now. Some offices are 100% digital, so they're not going to want these. So I just need to find out, like, who might use these. So the one concierge practice that I was talking about, they're like, we don't use these at all. You're on our list. If there's patients, we're going to send them to you. Don't worry. Like, thanks for asking, but we don't use these at all. Okay, cool. We move on from that. But then my buddy who lives nearby, that's a podiatrist, he lives 3 blocks away. I could have walked this over to his home. Of course, I didn't do that. What I do is I bring this physically into his office so that I make sure it's on his desk. And he said, this is Monday. Now it's Thursday. He goes, I'll probably have some referrals for you this week or next week. And this makes my life easier. So it's like, okay, like now he's different than this other concierge practice. This is going to make his life easier. So that means if we start getting some referrals, then that means I need to get this referral pad into his other office where he sees patients the other days, which I'm going to do tomorrow or this week or next week or whatever. And then follow up and see, like, is he going through the referral pads? And by the way, you're only going to drop off one of these at a time. Why? Why, Tony?
Because I want them to run out so that I can come back in. Plus, most of them are going to go in the trash. So I want a reason to restock their supply.
Exactly. So I'm also, in terms of just patient marketing, I'm also using these little thank you cards. So it's just like what do you call this? Like a 3x5, basically.
Sure. Yeah.
I'm using I got labels to make it really efficient. Of course, you could outsource this if you wanted to. Any patient that we speak with that's kind of like on the fence, that is like, I'd rather use Medicare, or have like a total knee replacement coming up, or, that's more than I thought it would be, or, we were referred to you and I thought they said you take Medicare, and we're like, no, we don't take Medicare. Here's why we don't take it. It's this dollar amount. And then some family was like, oh man, like $4,000 a month for PT. And
yeah,
I'm like, yeah. So then I wrote them a letter on this and I said, hello, so-and-so. We spoke recently. We're the practice that is, private and does not accept your Medicare. I want to make sure that you've gotten taken care of. Are you situated and happy with your Medicare-based physical therapist? ? If not, feel free to reach out anytime.
Yeah.
Put 1 or 2 business cards inside of this thing, mail it off with a 40-cent stamp or whatever stamps cost now, 60 cents or whatever. So we're using the same thank you note that I got on Vistaprint, which is, fairly cheap. We're using these paper letters to send to physicians that don't know us at all. We're sending these notes to physicians that do kind of know us. We're also sending it to leads, prospective patients that are on the fence. And at the same time, we're also we've done this in the past where we send this to current patients that just got evaluated. I know this takes money, time, effort, but we also send these to patients that just got evaluated. And it says, it's basically to reinforce their decision to work with us. So it's like, hey, you tried us for 1 or 2 visits. We're glad things are going well. And it's great to have you on board, and it's just another touch point where they get to see us. It's a different experience. No one else in the country is going to do this, is going to send a paper letter, thank you note to a new evaluation when it's so much easier to send this over a text or an email.
Yeah.
I know I'm throwing a lot at you guys. Let me know in the comments live here if you're listening, if any of this is resonating or helpful. Yes, it takes a few bucks. Yes, it takes some time. But listen, you only do this if you want to have more happy patients and clients that refer to you and love you guys and stay longer and are fine with paying more out of pocket instead of the top of the show, the third-party payer system.
Yeah. I mean, I love it. I love that you're doing, I would say this is something that doesn't scale. This is something that does, the time is the biggest cost to it. We used to do it before we got too busy to do it anymore. But there are a lot of therapists who want to get started. They're sitting there with more time than patients. This is the kind of stuff that they should be rolling out 1,000%. Now, Jimmy, you might not know yet. Does Athelis have systems in place to manage physician referral relationships or anything like that?
Not that I know of.
Yeah, I don't know.
Yeah, so what we're trying to do, so I should say not yet. Or if we do, I'm not working there yet, and there's some reasons I can't say.
Yeah. Stephen Dunn, of course, he's been sending notes after evaluations. I mean, there are people doing it.
There you go, Stephen. And that's why that's why he's been successful. It's not a lot of people. I can't imagine it being a lot of practice doing it.
Which strategies, Scott? Scott is saying, Dave, if you really want to be unique and successful with your marketing, use Chris Voss's strategies. I like everything Chris Voss says. Which ones do you think? Which ones are you excited with?
Well, I mean, Chris Voss's strategies around, like, Scott, you got to give me a little bit more detail there. Are you talking about like the questions?
Yeah, that's what I'm asking.
The framing of the questions. Yeah, Scott, give us a little bit more. Like, I'm trying to think of Chris Voss's questions that I could put in one of these letters to a physician, and it would be like, would it make sense to send us more of your patients? But that sounds almost like Tony's laughing. Like, that almost sounds too, like, I'm trying to game you. Like, I'm trying to like mess with you, right? Like, I'm trying to, like, it's maybe too much. I'm trying to think what else Chris Voss, how else could you use Chris Voss's strategies in this? I think
would you be against sending your patients to the best to the therapist?
No, you can't. No, you can't say that. You can't say the best though. That's
I can't say.
You can say, would it? Right. Listen, I've used the Chris Voss questions over text or email, and prospective patients, as smart as the average IQ is here, maybe in New York City, in my guesstimation, like, some people say like bad idea. They reply and they're like, it would be a bad idea. Like, sometimes the Chris Voss stuff, I think, maybe only works best over phone or in person.
15 years from now, I want Dave to come back and fill us in, because he's going to be using the Chris Voss stuff on his son. When his son is wanting to do things, he's going to be reverse engineering all of that.
Oh, I'm already. There was some book years ago from Dr. Spock. Dr. Spock something that
I remember.
It was, the title was something like it was like, don't tell your kid no. It was a different title. It was like how to not say no to your kid. So like, I'm trying that, and the best I can come up with my son when he's grabbing something that he shouldn't, is I say, hey. That's all I got so far, but that's not saying no. Scott, let me know in the details or in the comments below. I'm trying to think of some other
Well, let's turn the corner. We're coming down to the end of the show. I'm going to ask Dave specifically. I think Jimmy might have seen it. Did you see the clip that I shared on LinkedIn of Angie from Apex at Alex Hormozzi's live event?
I don't think so.
So that was the video that Will Boyd shared with us, Tony. You and I.
Oh, I totally didn't make that connection. Okay.
So that Will Boyd didn't even say her name. He was just like, hey, there's a physical therapist asking him a question and by the way, Hormozzi, they charge like $5,000 for that workshop for like a day or two.
Yeah. But you got to
fly to Vegas to their building. I did not see your post, Tony, but I did listen to her her video. So yeah, if you want to play it.
Just a super quick clip. I think the audio will play. It's just 16 seconds.
The wellness, so basically physical therapy, personal training, 35 to 45-year-old athletes.
Okay.
Ours is the avatar. We do about a little over 3 million. The biggest thing that's stopping me, I have a huge shortage in practitioners. To give context, there's about 16,000 open positions.
Okay. That's all that. I recorded the full 5-minute clip. Now, for context, and this would drive my wife crazy. You're right. Will Boyd shared that with us. It totally didn't click in my head. That was originally aired, I think, a couple weeks ago. I remember hearing it and thinking, oh, it's a physical therapist talking to Alex Hormozi. It didn't make the connection of who it was. Will sent us that message, and I was in the middle of a bunch of stuff, so I don't even know if I replied, but I know I saw it. Then yesterday, I'm laying for my 3 p.m. nap, and this is my routine, guys. So 3 p.m. before the kids get home, they usually roll in around 3:30. I put my phone on my chest, I close my eyes on the couch, and I know I'm going to get a 15-minute nap in while I'm listening to something, and I realized who was talking in the video. So I listened to the full clip. I grab it, but Alex Hormozi echoed what we have been saying forever, which is, look, at one point, yes, you are the therapist treating the patient. The patient is your target demographic. Then as your business develops, the patient is no longer who you're serving. You now become the owner of the business who is serving and trying to attract clinicians. And that's what Angie and Alex were talking about. It's like, okay, the target is not the patient anymore. She's doing 3 million in revenue. I think it's one location. They're building a new building. They're doing all this incredible stuff. But now her target is, I need therapists. And so Alex said, and I think there was a miscommunication, I think she meant to imply a therapist generates 350,000, but he asked for
the profit, right?
Yeah, it sounded like a therapist generates 350,000 in profit. Maybe that's what she's doing. I don't know. Regardless, I just saw a speech language pathologist say, hey, I'm struggling to find other SLPs. What if I charge $10 more an hour to take that $10 from the patient and use it to pay an SLP $10? And I'm like, $10? That's it? Like, what are we talking about?
Yeah, exactly.
So the point, and we'll save this for another episode. The point is, if you take the emotion out of it, if you take all the biases away, and okay, I can hire a clinician tomorrow and they're going to generate, let's say 100,000 in, more revenue than they cost me. I'm not going to say profit, but I'm going to say 100,000 and more revenue than they cost me. I mean, that's $100,000. You're going to offer them $10, $20. Like, it's a drop in the bucket compared to what they're actually bringing you. So why are we not seeing salaries jump 20,000, 30,000 instead of like 10%?
Because of the third party payer. We've talked about this, a full loop from the beginning to the end of the episode and onward.
I agree. I agree. Jimmy, what are you thinking?
For that particular situation?
Anything. I
mean, listen, this is the situation we're in now. If you'd like to change culture and the entire system, have at it. But if someone is looking at how do they make payroll tomorrow or 6 months from now, changing the system is impossible. Now, you can go outside the system, and that is like flying without a net. 100% think that there are people who are doing that now and 6 months from now and 6 years now who will be. There's a different way to do it within the system until the system change.
Yeah. All right, guys, let's wrap it up. What are the parting shots? Mine, just real quick, I think we've outgrown the profession. I think this little bubble has outgrown the profession. We don't need the restrictions of licensure. It used to be an ATM. It is no longer an ATM. There's no benefit to licensure anymore for most of the people listening to this show. So that's my take on it. And I'm not going to waste my time trying to drag the rest of the profession up. I'm just going to move to where the successful people are already. Dave, what you got?
Love it. I think that we've outgrown the third-party payer system, the fee schedule, whatever you want to call it, the insurance companies. Jackie's here. She said totally agreed. She's probably agreeing with something Tony said, most likely. No. But yeah, look elsewhere. Got nothing to sell you, but it certainly is possible in a lot of metros and a lot of states, and even Jackie in a small Ohio town charging out of pocket for physical therapy, performance related services. So sky's the limit. You gotta put a lot of effort into stepping into it and growing into that.
Yeah.
Jimmy?
Yeah, the system produces the results it's designed to produce. Like if you don't like the results, then either change the system or change which system you're in. And you are free to make those choices. Now with those choices come pain points, right? The sky is the limit, but I've never touched a cloud. Like I could figure out how to get up there, but I decided to just go through someone else's system and get on a plane. I will be getting on a plane again next week, and I will look just as beautiful as I am the next morning when I get off that plane. But I'll be in Denver. I'm going to do like we used to do as pub nights back in the day. I'll be out in Denver for some work. And Thursday night, if you want to, I don't know, shake some hands, learn some strategies from colleagues in Denver, make some connections, maybe hire a therapist or whatever. We're going to have the location, the time. My buddy David from PT School is going to pick a place for us to hang out and meet up for a couple hours. So we'll have that information pending.
Awesome, buddy. Well, we are done, guys. Go check out the Dave Kittle Show on YouTube, the podcast. Go check out PT Pintcast. Follow Jimmy's journey to see what he does next, and check out Learn Medicare Billing.
Hey, it's Dave Kittle. Are you a healthcare business owner or physical therapy practice owner who is looking to figure out your succession plan or exit strategy? We might be able to help. And in fact, we may be interested in acquiring your practice. If you're interested, you can reach out to me. Shoot me an email at dave@conciergepainrelief.com. That's DAVE at CONCIERGE painrelief.com. Or you can call me at any time, 646-781-8884.